Hi, I'm Dr. Scott Worden, the TOS guy, and we are live streaming from beautiful Sunnyvale, California. Today, it's actually more like Rainyvale. We've gotten a bunch of storms, but that's good for California. Hello to all our visitors. Today, we have a really unique show. This is the first time we've done this. You may recognize Steve Talakowski, a physical therapist that has been a guest of ours several times, but today, we brought in also two other highly experienced expert physical therapists who deal with thoracic outlet syndrome in their practice. Liz Scarpelli, say hi, Liz.
Hi.
And Janice Tamita, hi.
Hi.
And Steve, hi. Good to see you again.
Hey, I'm glad. Thanks for having me here again. Thank you.
We would love for our patients to see, first of all, what the value of physical therapy is in a good thoracic outlet syndrome treatment program. And secondly, what each of you treats differently, what kind of patients you see, and how you do it differently. So, Steve, I'm going to start with you because you worked with Peter Edgelow for many years, and I think many people in the physical therapy community are familiar with his work, and you've taken it further. Why don't you give us a brief overview of what you do?
Thanks again for bringing that up. I worked with Peter for 14 years, and I've been at the same clinic that we worked at together. It's been 27 years now, but I am using Peter's program, and the more I learn to use it, the more I value it. So we'll start from there. I also have experience with other problems because a lot of my thoracic outlet patients have secondary problems involving the spine, it could be the neck, thoracic, lumbar, the shoulder, even other issues with the knee, which I'll maybe get to later. And so what I'm trying to do is take Peter's program and then address not only the thoracic outlet component, but how those other issues are playing into this whole problem, and then trying to sort of solve these different problems by not aggravating something else. And unfortunately, a lot of my patients come in and they see a therapist who might not be experienced in thoracic outlet, and then what they're doing are things that are probably too much. A lot of strengthening, nerve glides, things that might not be bad for certain patients, but they're not bad for a thoracic outlet patient, at least not a thoracic outlet patient that has irritable symptoms. So I'm using Peter's program. I'm bringing in my own experience with other issues, and I'm trying to, put this plan together that works for all the problems that they have.
Liz, how long have you been in practice?
48 years.
Wow, that's amazing.
Yeah. I told you I did it when I was 12.
Love it. What kind of changes have you seen in your practice over that short period of time?
Oh my gosh. Well, I started out in neuro and spinal cord injury and head trauma, and then a wonderful PT from Australia, Jim Lin, came to San Francisco to teach for 2 weeks, and I fell in love with orthopedics. He was a fantastic physical therapist. And then I went through the Kaiser residency program, right? And then at some point I started teaching the program. And over the years, we had some fantastic years of manual therapists really doing excellent examinations, teaching our students not to over treat, because in thoracic outlet, you can over-treat and you can be too aggressive, and then you take 10 steps back. And I think another thing that is critical just in healthcare in general is listen to the patient. A lot of these patients are not listened to. They are poo-pooed. Plenty of doctors don't believe they have any of these symptoms. And I think one very big thing, and I try to teach all my students, was listen to the patient. Ask constructive questions. Don't blame. Just keep open. And that, I think, is something that's super important. And I unfortunately don't think people are doing it anymore, because it's easier just to hand a handout to a patient than it is to actually examine and treat them.
Do you feel that's following the general trend of medicine nowadays of more patients per hour?
Yep. And I think it's tragic. And I think we're missing a lot of people that are severely injured, whether it's a car accident or it's overuse or it's a fall, a lot of people end up being dissed as if it's not a problem. Or you just get over it, and it's like, you know what, if you take the time to sort out what's going on and you get your patient on side, a lot of times you can make those changes that nobody else could because you listen to the patient. They trust you.
I want to come back to that later, but first I want to get Janice, who I think also started at 12. Janice, how long have you been in practice?
A long time.
Well, you don't have to say exactly, but I didn't introduce everybody, but we're all in the Bay Area, different parts of the Bay Area. Janice, you're in Mill Valley and Marin.
Right, that's correct.
So what kind of patients do you see in general with TOS, or is it a broad range?
I see, patients that have had multiple diagnoses. So some of the patients, have had cervical laminectomies, but then after the cervical laminectomies, they still have the symptoms. So then, they seek out other treatment, and then they're diagnosed with TOS. I see patients that have had hand and wrist surgeries that now have ended up, developing TOS as a compensation to their wrist and hand surgeries. I see patients that have Ehlers-Danlos that also has TOS. So, and I see patients with posterior labral tears that also have TOS symptoms. So I see a vast array of
So a
patients.
cluster of upper extremity, upper quarter diseases that are different, but you feel are associated.
Yes, I believe so.
And
But they will present themselves like, they have arm pain, or they'll have, severe hand pain. But, the hand surgeon will say, oh, it's just a mild case of carpal tunnel, and then the referral is made for TOS. So
Do you all feel what Janice has brought up, that physicians are not diagnosing TOS patients accurately?
correct.
Yep.
Well, I mean, I think that these patients are very complex because, they're not. I think there's several diagnoses going on, but then the primary one has to be discerned, and oftentimes it's not.
Well,
Because
do you
people
feel
that
we
have
need to treat?
cervical laminectomies, and they have the surgery, and then they still have the symptoms, and then they seek out other types of care.
Mhm.
Liz, is that something, Liz,
Yeah,
you've seen this same?
I think the thing that's really upsetting is that patients come in and, like Janice said, they can be really complicated. And you may not even know the first time you see them that it's TOS, but it's just, it's being able to parse out things, and by a process of elimination or addition, you're putting the story together. And I think that a lot of doctors, especially now, they don't have the time. We don't have it either, but we're doing it to really figure these people out, because they've lost the work, they've lost their social life, they lose a lot of things. And it's really critical that somebody can kind of go in and figure out how many, because plenty of people, if you don't move your shoulder, well, you can have a problem here. If you don't move your hand, I had a doctor tell me, treat the hand. I said, it's not the hand, it's his neck, her neck. And you treat the hand, you're insubordinate. And I said, I'm sending the patient back to you because it's not her hand, it's her neck. And in this case, I went back to the patient and said, you need a lawyer. And she did. And she had to have a 2-level fusion. Not thoracic outlet, but it's that same thing of, you need to listen to the patient, you need to examine them carefully, and then come up to, and sometimes we're wrong. I understand that. But, you're trying to make the best possible evaluation for people, and trying to listen to them and see what are the things that I need to ask them for to know what's going on with them.
I will say that we consult with hundreds of patients here at TOS MRI, Vanguard Specialty Imaging, and it's shocking sometimes to me how many patients first got the diagnosis or first heard of the disease from their physical therapist. And I've often thought it's because the physical therapist has to spend more time with the patient and has to observe subtleties that maybe many doctors, physicians don't.
Mhm.
What I've also found is things work best for a lot of patients when we have everybody working together. I've never said to a physical therapist, you can't be right, because with my luck, I will be the one who's wrong. And I'll just, having a stone head doesn't help anybody.
Right.
Steve,
But
how do you work with physicians when they don't have the time or knowledge to diagnose TOS? How do you handle that situation if you firmly believe a patient has TOS?
It's hard sometimes. It's hard to tell today. It's hard to tell a physician that the patient has thoracic outlet syndrome. So, and I think I'm going to go back a step, because I think part of it is, like we've all been saying, these are complicated patients, and there's very few thoracic outlet syndrome doctors, if there's any. There's neurologists that might specialize in it, but
mhm.
most of these patients if they have a cervical issue, a shoulder issue, like a peripheral nerve problem, and thoracic outlet, there's no one doctor that understands all those things. Matter of fact, there's not a lot of physical therapists that understand all those things. I mean, everything's become so specialized that you see a patient sees their spine doctor and they say, well, you have a mild bulging disc. I don't think that's explaining your symptoms. Or they have a shoulder injury. Well, I don't think that's explaining your symptoms. But they're not able to go that next step. At least a lot of them aren't. So it is up to the physical therapist to put all these pieces together and make sense of it. But also it's up to us, because we're looking for that. I mean, I am, at least, and it sounds like everybody else in this group is looking at it. And a lot of therapists aren't looking at it. They're following the orders of the doctor, or they're looking at it as a neck issue, a shoulder issue, a peripheral arm nerve compression issue. I get therapists who haven't seen a thoracic outlet patient maybe once in their entire career, and they have no clue how to treat them. My only benefit is that that's what I'm looking for now. Every patient that comes in almost is they're coming to me because they think they have something. They're not sure what it is. So I think we talked about this earlier I think what's driving all this is the patient and the internet and getting information like we are right here. Patients are looking for answers, and they're not always getting them from their doctor.
That is really
they're getting it from online. They're getting them from other people, from support groups, from, again, things like we're doing here. And a lot of my patients are coming in. I saw your name. I heard you online. I did this. I asked my doctor, could I see this guy that does thoracic outlet syndrome? And a lot of times the doctors say, sure. Because it's not that they don't want to help. They just don't know what to do.
So thank you for the little space I'm going to take here. Everybody who's watching, please make sure you subscribe to us and hit the little bell that says you'll be notified when we have a new live stream, and hit the like button, because the algorithm makes a big difference, and we want to spread this to a lot of other patients and care providers. Thank you for the opening, Steve. It worked perfectly. All right. So I think we all know a now retired neurologist, Dr. Tracy Newkirk, who's pretty, famous in the field. I had several years ago a mom come to me trying to help her son out, and she had seen a hand surgeon in San Francisco who got on the phone and called me while she was in his office. And we talked about thoracic outlet syndrome, and she said it can't be that, because her neighbor down the street told her Tracy Newkirk diagnoses too much thoracic outlet syndrome. And I told the mom, maybe that's just because he sees all these patients that no one else can diagnose. And in some communities, we still feel that there isn't a specialist. This is among physicians. And I think those are communities where it's ripe for a good therapist to bring up that possibility. So again, it reinforces the fact that as part of a care team for patients, I think most patients need more than one specialist. I don't think any of you have treated a patient successfully by yourselves without a doc who's willing to listen to you and work and encourage the patient to follow what you do.
And I also think, Scott, that we need to have some ability to show validity of the MRI, because a lot of doctors poo-poo that. Oh, that's just BS. I mean, and this is what it's like. Okay, so how are you diagnosing it? This is showing that there's no blood going through. So I think that the MRA is a really critical piece of the diagnosis.
Well, thank you. Obviously, Liz, we deal with some of that resistance and dogma, still at some very high levels. And I've been reviewing papers from the literature, and there's so much support for it in cold, hard numbers. But human beings are human beings, and doctors are still human beings.
And bean counters are still making decisions for doctors.
Oh, yeah, that's very true. That's very true. We have all kinds of trouble with insurance with our patients.
Right.
But what Steve brought up, and I think what we all feel, hopefully, is that the internet does empower patients. They need to get their diagnosis. I think, I don't know what you think, Janice, have you ever had a patient change their approach because they got a name, thoracic outlet syndrome? This is what I have.
Whose approach are you asking?
Well, what I've seen is some patients feel so relieved when they finally have a name for their disease and they can go look it up. And they just seem to be strengthened by that. I don't know if you've experienced that when you're on an ongoing course treating a patient, if they've been encouraged, strengthened, empowered by having finally a diagnosis.
Well, I mean, since I work with Tracy, he just would make the diagnosis, so it was just pretty straightforward. Yeah. But yeah.
When
So
you
I've
deal with
been
other patients who are
fortunate.
referred to you, let's say, with an upper extremity problem, but the doc doesn't mention TOS.
The physicians that refer to me, they say it's TOS. They make the diagnosis.
Good.
Yeah. Because they're like the hand specialists, they'll rule out carpal tunnel, and the testing on it is a mild case. So then they will refer them on to me.
So you're a problem solver for a lot of these docs. That's great.
Yeah, I mean, because in Marin County, Hillary Redland, she's an excellent hand specialist. She'll do the diagnostic testing for the hand and the wrist, and if it's negative, then she'll refer them on, seeing it's TOS.
Excellent.
And patients that have issues, with the shoulders, then she'll still refer them on to TOS. So she's excellent in terms of making the proper referral, because every time she's been accurate.
That's great. And you said that's Dr. Hillary Redland?
Yes.
Excellent.
And the last client she sent me was a water polo coach. And apparently Hillary Redland was a water polo player at Stanford. And she was on the first women's team for water polo. So the patient closely identified with her. And, a lot of that overhead, with water polo triggered her symptoms. And so when Hillary says, "Oh, I know exactly what you have TOS," then the patient goes, "Yeah, I'm pretty sure I have that." Yeah.
Have you, Liz or Steve, found that that's helpful to patients when they understand what they have and they go research it for themselves?
I was going to say something, because my experience is that people there's probably two emotions. One is, thank God I have a name for this. And then I think they're terrified.
Mhm.
I think they're literally terrified because of what they hear online, of what they read, of some of the people that are suffering with it. So it's a bit of a kind of a bittersweet um, moment when someone says you have thoracic outlet syndrome. And so and of course you hear about surgery and then you're thinking the worst. So I think part of what I try to do is reassure them that a lot of folks get better with conservative treatment. There are people that get surgery, but the majority of people are going to get better with conservative treatment, and to have hope and then to let them know that we have a plan that can help. And now that a lot of times when people step through that door and they meet you, Scott, and they get a diagnosis, or they meet a doctor that understands thoracic outlet, or they meet one of the therapists here that understand it. I tell them, you're finally, all the mistakes you were making in the past, we're not going to make those. We're going to try to correct all those mistakes, and we're going to do our best to help you. But I tell you, it's scary. It is. I think it is. I mean, and it's a horrible feeling, but also it's a good feeling to know that there's people that actually understand it. And again, to feel like for all these years, people have been denying my reality, and finally somebody is putting a word or a name to it. And I think there's at least some relief in that, knowing that.
Liz, how do you feel on that subject?
Well, it's interesting because I have seen so many different kinds of thoracic outlet patients. I see patients that end up, their arms swells and they go to emergency surgery because they have a blood clot. I've seen one in a 23-year-old girl. So people think, oh, you're older and you've got bad posture and this. And it's not always the case. So that's what makes it so complicated. Each patient is individual, and you have to look at their body type, what they do for a living, if student or athlete, or there's so many variables here, and trying to put them together is what's tough. But I think, sometimes surgery is the only answer, especially when you have blood clots. But I think a lot of people can get help. I have some that have surgery and are no better. This is also the problem. They've had first ribs removed. I actually had one patient who went to some guy down at Stanford and he did an elbow release. And I've actually had two of them, total failures, because that's not where the problem was coming. And then the first rib removal. So everybody doesn't get better, but those are unusual cases. I don't think those are the bulk. Those are the ones you remember so much because those people
Good point.
to have treatment for the rest of their life on some level. But that's the small group.
Occasionally, we discuss on this live stream social media, and for all our patients who are watching, I'd like to remind you we're talking with specialists who have years of training and experience. When you're in a Facebook forum with a moderator who has a point of view, you got to be careful. They're not doctors, and they tend over time to like the attention they get from running a forum. And we've seen many examples of this where they're just flat out wrong, or they have bad things to say about doctors that we know that are helpful. And they end up with just a depressed group of participants. As Steve brought up, the emotional burden for this disease is not insignificant.
Right.
And so it's helpful to find places where maybe people are a little more positive, have had better results. In my experience in this over 25 years, roughly, we have seen a lot more awareness of the disease and a lot more docs and therapists and people sort of coming out of the woodwork who've been doing it for a long time that we found by luck through patients who tell us of good results. So got to be careful with social media, and you got to find good specialists. And I'll remind people at Vanguard Specialty Imaging, TOSMRI.com, we always give out names of doctors and specialists in your area. If you reach out to us, there's no charge for that. We'll help you find somebody as close as we can. And if you are a provider out there and you happen to be watching this, reach out to us, because we'll put you on our interactive map, and we'll certainly include you when we find patients who need assistance. I'll get off that little soapbox. Um, what do you think is the most important factor or the most important factors that give a patient a good prognosis from the moment you first see them? Can I start with Janice?
I think that, if the patient is invested in getting better, then they're going to do everything possible to listen to your guidance and direction. And I've only had a few patients that have not gotten better, but those are the more difficult cases with the Ehlers-Danlos, because
Mhm.
that disease process is very debilitating for anybody. And those patients are just, in so much pain. But the rest of them, they do fairly well.
Do you find that the course is shortened in like young athletes, maybe people who are in really good aerobic shape?
Yes, because I think I told you recently I treated a water polo coach, and it was the quickest turnaround time. I think it was like maybe 6 weeks.
That's great.
Yeah, but they have the body awareness that the average person doesn't have, and so that puts them ahead of most people, and they're in excellent shape. So it makes a big difference. Yeah, definitely.
So is that part of your work teaching people how to be kind of biofeedback, how to be aware of their breathing, their body, their posture?
Yes, I mean, it's amazing, when people have upper quadrant symptoms, that they oftentimes will, automatically engage their upper traps, but it oftentimes is an indication of something more serious going on with their bodies, either a shoulder issue or a cervical disc issue or a thoracic issue or a TMD issue. It's a red flag that there's something going on with the upper quarter, and a lot of people don't really treat the upper trap as being very serious, but it's just a way to let you know that there's something more underlying going on.
So it's sort of a guarding reflex. They try to
Yes, because
stabilize.
because like if a person have a cervical disc issue, then immediately they elevate their shoulders. If they have a posterior labral tear of the shoulder, then their shoulders drooping forward. You know, if they have a thoracic issue, then they're usually slumped forward. So I mean, all of those are indicators that that person has a more serious problem underlying the upper trap symptoms. I don't know. What do you guys think?
Well, well, if you're asking what I think what Scott was asking, what do I use to kind of uh, determine how successful the program will be? I think that was your question, right? Originally, was that the original
Right.
question,
But
Scott?
I
Yeah.
also find this question about the trap very interesting. I just haven't heard it before.
Oh, yeah. I wasn't sure if you're asking about that specific. I mean, it does go back to there are so many versions of this that it's hard to give an answer. It's just there's so many ways this can present itself. There's so many confounding problems. It's a person's age. It's how they got hurt, how long they've been hurt, the irritability of their nervous system. Uh, and when I use in the Edgelo program, one of the things that we do that there's a really big emphasis on objective measurements. And so day one, when I see a patient and I give them an exercise, I am looking for that day some sort of improvement, whether it's range of motion, strength, hand temperature. There's a number of things that we look at. And if that person responds positively, even that first day, I've always felt that's been a good sign that there's potential to improve. Now, people sometimes don't improve that first day, but I think, that I'm looking for then is what is their how determined are they to follow the program? And then eventually that improvement happens. But I expect people day one to make a meaningful, albeit temporary, improvement. And I think that can help drive the motivation to continue with the program, because it takes time. In some cases, it takes a lot of time.
Right.
Matter of fact, in most cases, it takes a lot of time. It's not a thing that gets better in 6 weeks or 3 months. I mean, you can see changes in 6 weeks and 3 months, but you're not going to see recovery in that short of time. And giving people realistic goals.
Liz, how do you feel about prognostic factors that you might be aware of?
I'll tell you, a patient walks in and they're in horribly slumped sitting posture. And I thought, okay, we got to deal with that on the very beginning, because I think especially because so many people sit at a desk all day, right? So trying to see if I can get them into a neutral position, it's amazing how a patient goes, wow, I can't believe that helps my back, or that helps the back of my neck. And yes, it's not necessarily all thoracic outlet, but it's we know that we can change position of tissue, that can improve. And so I always start, besides asking all the questions, is watching them walk through the room, watching how they undress. In most cases, I'm allowed to do that, right? And you see somebody really having difficulty fumbling with their clothes, hard to get it over their head. And it's like, okay, let's talk about how we can make your life easier. Button shirts instead of things that are going over your head, looser fitting. You start teaching them all these kind of things, and they feel, wow, somebody's got a hold of this a little bit. I feel that I can do what they're asking. I'm not asking them to do a ton, but I am asking them, what's the position that you sleep at night? Let me see how you position yourself. A lot of times I'll have them bring in their pillows, because their pillows problem. So I think the prognosticators are really over time, but when they walk through that door and that posture is a mess and they're really in the snail position, that's the worry. And back to, I had a young guy who is a trumpet player, and this was what he was going back to school for, music. And he was absolutely going to do this no matter what. And I said, if you can back off a little bit, and if you cannot be gung-ho so much that you will play regardless of if that's going to bug you. If we can step you back to the very beginning, start with 3 minutes that you're going to do it, and you're going to do it in front of the mirror, and you're going to watch your posture. If they buy into that, that's a good thing. But again, like Steve said, it is such a long process, and a lot of it depends on how the heck long they've had it and how bad the symptoms are. So there's so many variables.
Thank you. How about, any of you see post-op patients?
Yes, lots of
We
them.
all do.
Oh, you mean for TOS?
For TOS.
Yes, I've seen some.
Mm-hmm.
What is your
But
experience?
It's I think her name is
No patient.
Dr. Ghislaine Jacques. She sees, she's a neurologist, and she treats TOS patients. So the most recent case that I saw that she referred was the woman had pain in her arms and burning sensation in her hands. And so she did, let me see, I have it written down. Wait a second. So she did a brachial plexus neurolysis, and she did a C5, C6 trunk, and C7 middle trunk, and C8T1 lower trunk neurolysis. And then she did a scalenectomy of the anterior middle scalings. And then she also did a subclavian anterior lysis. And and I saw her for approximately a year after surgery, and the patient had we cleared up all her symptoms, because the symptoms right after the surgery were the same as before the surgery. So, but she was doing a desk job, And so she was, like Liz says, that her posture was, in a stooped over position. And so she had the pain for about a year ahead of time. And but then with the physical therapy, working on posture, body mechanics, and educating her, then she was able to be pain-free at the end of a year.
Janice, did she have a first rib removal as well?
No, she did not.
That's amazing. Okay.
Yeah, she just did a C5, C6 upper trunk and a C7 middle trunk and a C8, T1 lower trunk neurolysis.
Wow.
This is, you said Dr. Shaw, is that a neurosurgeon or a neurologist?
She is Dr. Ghislaine Jacques. She's French. She's at UCSF, and she is a neurosurgeon.
Okay.
And that's who they generally refer people for TOS up at UC.
So there is some literature out there, which I've recently reviewed, on what's called rib-sparing scalenectomies, or decompressing the thoracic outlet without the first rib.
Yes.
Which is, and this is important literature because I think there are many different pathologies underlying the disease. I see patients who come to me with obvious TOS clinically, and they don't have that space narrowed. And so why do a first rib resection in those, right? So there is literature, and what it shows is, first of all, it shows not really great results for any surgery, but no difference between taking the rib and not. The only problem is the selection of the group of patients is just based on the clinical diagnosis of TOS. There's no imaging. Now, of course, I want imaging. I'm trained in this. This is what I do. But you would never go to any other major surgery without imaging. We overuse imaging. So my little pet peeve, and it's not so little, is how do patients ever go to such a major surgery without knowing what's going on? Is a surgeon just putting on one of those coal miner hats with a flashlight and taking a pick and walking into the cave? I exaggerate. I am glad to hear the success of this, though, this kind of approach, Janice. You had a patient who had no improvement from surgery, and then you got the improvement by your work. So that's encouraging.
Right, but I mean, it could have been because there was inflammation after the surgery. And so the inflammation takes a while for it to calm down, and then your work begins. Yeah.
Well, Steve focuses on inflammation and that being a first approach, right?
Yeah. I mean, I even right now, I probably have a half a dozen post-op thoracic outlet patients, and thank God they're most of them are doing pretty well now. They're still they're still in kind of the middle or the beginning of their journey. So it's hard to say what's going to happen 6 months or a year from now. Sometimes you don't see those patients 6 months or a year from now. So sometimes they you see them initially. It could be an insurance thing. It could just be whatever, and you're not with them the entire time. I do have people I kind of contact later because I keep in touch with them and ask them how it's going. And it's a little bit of everything. Some people are a lot better, some people are better, but not as much as they thought. Some people realize now that they have other problems that the thoracic outlet surgery was not going to fix, so they need to deal with that. Sometimes the therapist they're seeing after surgery, and it's not always me because they may live somewhere that's a bit of a drive, are too aggressive with them. That happens a bit where I think people are just getting into all the things I told them not to do before the surgery, and they're doing them right away as soon as the post-op. So it's a little frustrating that there's not a better plan post-op sometimes. It's almost like they're kind of left out. They're kind of just left to manage it themselves.
And I think one issue you also have is that you have a lot of therapists have heard, neural tension gliding. I've seen this all, so much, and they do this stuff before we even know if the joint can handle it. So they really stir their patients up. And this is not just thoracic, this is cervical disc problems and nerve irritation. And it's like, I just want people to think, back off. If you're causing symptoms down their arm, it's probably not a good idea to do this, you know?
Right.
And it's pay attention to the patient, ask questions. You know, I can't tell you how that interface between us and the patient is like the critical piece. It's absolutely critical that they know we're on their side and that we are listening to them, listening to their tissue, not just the.
So I'm going to ask one more question, which is just an opinion piece. What is the one thing that you think we're getting right about TOS now that we didn't before? And what is the one thing that you think is not as good as what we've done for the past 5, 10, 20 years? Steve, can I call on you?
Yeah, sure. Well, I think what we're doing right is this. I mean, and I'm being serious. I think I don't think the knowledge of people that know how to treat this. I don't think there's more people out there. I think there's probably same or less. So what I think we're doing right is that we have this ability to kind of cross over boundaries and state lines and go all over the world and teach people, because there are people that are interested in it, and through technology we can kind of link people together. So I think what we're doing right now is what we're doing right at this moment, and we're getting all those people together because we can. I think what's bad is that I think the healthcare system is overworked and overwhelmed, and I think things are so specialized that people can't see it. They can only see what's in front of them, and you have to specialize in this to be good at it. And who wants to specialize in it? I mean, I think Liz said something earlier about there's not enough time to do this, but still we do it anyway. We take the extra time to see patients. When I have my patients, I spend more time with those patients than any patients I have. And I'm thankful that the clinic has allowed me to spend more time because I need to spend more time. And so, but the way the system is, it's more patients, the reimbursement hasn't gone up. And I don't see how therapists today are going to find a way to do this, because I'm at a point in my career where I can kind of back off the rest of it and focus on this. But if you're trying to make, mortgage payment and pay your student loan, spending an hour with the patient is not a way to do that.
Janice, can I ask you your thoughts on those two? What's going well and getting better and what's maybe not as good?
Well, I think that, there's not enough people that specialize in TOS. And so the more educating the public and having, therapists and physicians have a increased interest in the area of TOS will make it much better in the future. And I think that you have to have a broad understanding of all the different systems so that you could rule out the proper diagnosis, because otherwise then patients get very frustrated if they are being misdiagnosed and then treated, and then misdiagnosed and then treated. So it's really important that the physicians refer people that know about TOS, and then the patient can get the proper treatment.
Thank you. And Liz?
Well, I think one thing that was terrific was mentoring. I think, and it's just, this goes for every aspect in healthcare. Physicians, residents need to be mentored, by senior doctors. Physical therapists need to mentor their young staff. And the problem is we're not given the time anymore to do any of that, right? And, before I used to be able to, and I've had like 35 young PTs in my office over the years, and I mentored them. And you sit down and you're going to go through their chart and you're going to team treat. You're going to see that patient together. And it was a great thing. And now it's missing. It's gone because when you're getting paid $77 to treat a Blue Shield patient, you don't have time because you're just trying to pay the rent, right? So I think that's the tragic thing of not having mentoring. And I think it's these kids have to pay just such gigantic bills, 150,000, 200,000 to get out of school. So they're going for the places where they can just make the most money, and they're not getting mentored there. You know, the UCs, the Sutters, the Kaisers, they pay a lot more than a private practice, but they don't get the mentoring, you know, and that's the tragedy, you know, and I'm not sure. The upside that Steve said is, yes, we're on the internet and stuff like that. The downside is I feel like we're fighting Goliath.
Oh, well, hopefully the three of you are in great demand because of your skills and experience. I know we send people to you. We give your names out. We're going to take a couple questions here from viewers, if we would, Herb. And Naturally Raw says, is Dr. Tracy Newkirk's vest still available? Have you all, any of you, worked with Tracy Newkirk and his vest?
Yes.
I thought he was still. I thought there was something that someone said that they were still available, I believe, but that could probably change at any moment. So I would say there's a chance there still is a vest available.
Have you found that you can make progress, any of you, working with his vest and making the adjustments that are a part of it?
I found that patients that did get the vest benefited tremendously in the first, probably 3 to 6 months, because it helped them to be more aware of their posture and, know how to hold the right posture, doing different activities. It made a big difference for quite a few of his patients. Although it was very expensive, though. Mm-hmm. It was like $4,000.
Yeah.
Yeah.
I had a mixed experience. Some people I think it was very helpful for, and other people not. And I think part of the problem was it kept the problems of refitting and refitting and refitting and refitting, and that was difficult. I actually liked the first brace that he created way back when he asked me to take a look at it, and I thought it was the best brace possible. The only problem was it had 3 seams or 4 seams underneath the arm, and that was like, I said, Tracy, you can't do that. And then unfortunately the lawyers came in and said, you can't have that physical therapist looking at that anymore because she'll take your idea. It's like, that's the last thing I wanted to do. But I think the brace was a mixed bag in some ways, and it was extremely expensive.
I would say if anybody has questions about the vest, please reach out to us at tosmri.com. I don't know the status. I've seen them on a limited basis, but I'm not sure he's producing them in great numbers. So reach out to us, and thank you for the question. Marcus Hinkle, Steve, can you give any links to tools that Peter used to sell? I felt that Edgelow was using a thicker plastic bag to adjust the height for a gentle T-spine mobilization with breathing strategies. He had a website and he sold some of these informational items, right?
Yeah, I have, if you're talking about the airbags, I have airbags, and I give them to patients and people that I see remotely. I also make the pinky ball, which is not hard to make, but it's a ball and stick. So those are the couple things that I've been doing. There's still the Edgelow handout, which is the protocol, which we still use. The other equipment is a foam roller and a exercise ball or a small 3-inch roller, and then the sort of the magic what's the word I can use, and that's not what I meant, is checking thumb strength. which is a little more complicated. So it's kind of hard to just tell someone to buy something, but there is a thumb strength device that Peter kind of MacGyvered together, that people can make. And I've told people how to make it as well. So, but the things that are probably harder to get might be the airbags, although, I do have them. So if somebody was interested in, getting some of those, I'd be willing to help.
We if you reach out to us at Vanguard, we can help connect you with Steve through email. Thank you. Tate asks, in your experiences, are some TOS patients able to return to regular overhead movement of the arm without eliciting symptoms using conservative treatment without surgery? Janice, you want to take this first?
Yes, but it is a challenge though, because like I said, the most recent client that I had was the water polo coach, and she, even though we were able to get rid of most of her TOS symptoms, when she does overhead activities, it kind of brings back, like some symptoms, but it dissipates after the arms come down again. So I think it's touch and go for overhead activities.
I agree.
Yeah.
Liz, you said you agree with that.
I do.
Mm-hmm.
Steve, any thoughts?
I mean, it can be, but I tell every patient, I'm expecting you to return back to normal activity. Whether you do or not is determined, but the goal is to get back to normal activity. And so I never discourage people up front that they're not going to get there. I think you have to have that as a goal. And then at some point you start, you make your decisions as to what's important in your life. But I'll go back, I think I want people to be better, and some are, and maybe some can't do certain things. But I think most people would just rather, hey, if I can work and not be in pain and not have if my life can be back to some sense of, normalcy. And if there's a couple things maybe a person can't do, that's probably a reasonable sacrifice.
I think one of the biggest problems with the overhead is the repetitive nature and prolonged. The guys that's painting the ceiling, or that they're putting up sheetrock. I mean, all that stuff above head that's prolonged. I mean, it's going to tax normal people, right? So,
well, that's true,
definitely.
yeah.
So I think the thing about there is, I think people do need a reality check at the same time. It's like, look, this is possibility. Maybe you can get better. And do you want to risk it doing overhead prolonged stuff? That's to me the issue. And I think that it's important to also be realistic so that we don't disappoint them and they're angry because they can't do that. Because some things are just, I think, going to be impossible for certain people. Again, depending on anatomy, et cetera, et cetera, et cetera, a lot of that stuff.
Yeah, but you would say that with a shoulder patient or a cervical patient as well. I mean,
Right.
So I think, I also want to get away from the idea that somehow thoracic outlet is this sort of totally bizarre problem that is different than everything else. It's not. It's just, it's a problem that has a diagnosis and a treatment plan, and depending on where it lands is depending on how severe it is and how we can treat it will determine the outcome. But I mean, I think there's a chance that you can't, but there's also a chance with a lot of other people that they should not go back to that job.
Mm-hmm.
But it's wait and see, and it's hard to tell someone to change their career
For sure.
unless they have to.
Mm-hmm.
Thank you, Tate, for the question. Colleen asks, what are the top 3 exercises that you recommend to help the symptoms, I presume, of the 3 types of TOS: venous, arterial, and neurogenic.
3.
Top 3.
Well, I mean, we've been saying this all along. It has to be a postural change. And if you want to say that's an exercise, there's a lot of ways to change, a lot of things we need to do to change posture, but it has to be posture. For me, doing the edge low exercises at the very beginning are, working on diaphragmatic breathing to relax the scalenes and pec minor. And then understanding that there are things that you are probably doing that you should not be doing that are aggravating it. So when people come in and are still doing nerve glides and strengthening, and I'm going, so stop those things. So stop irritating it, calm it down, and get a better position to open things up.
Any other thoughts, Liz or Janice?
Well, I agree with Steve on posture. I think it's one critical piece. I think sometimes I will tend to work away from the worst part of the problem. So I might decide on doing a straight leg raise with someone to get the neural tension moving in a way and through the nervous system that is not going to aggravate the scalene. So I might do something like that, moving away and very gently. I think, again, in the beginning, you have to be really careful about how vigorous you are with these patients, because I think you set them back. We also use rubs balls, which are these little tiny balls. They're very small, like this. And I find that a lot of people who work these against the wall just to start to desensitize their soft tissue has been helpful. So they'll just roll on these for 1 or 2 minutes. They'll do it a few times a day. And I also think that one of my favorites is to start with external rotation, to draw the shoulder blade back, and to have people work on the breathing here, and to see. I don't want them to cause symptoms, so I think you have to be sure that they're not doing it excessively, and it's just trying to open up the chest and stretch pec minor, tiny bit at a time.
Janice, any additional thoughts?
Yes, so I agree with Liz, that the posture is very critical, and the you can open up the pec minor by having them lie on a foam roller and doing the angel pose to open it up so that you can get more venous return in the TOS. And I also believe that if we educate the patients on getting the scapula and the proper posturing, and meaning that you want to depress the scapula and then you want to downwardly rotate, then when the scapula is in a neutral position, then the patient will get more relief of their TOS.
Thank you. I want to thank each one of our guests. Thank you, Liz Scarpelli. Thank you, Janice Tamita. Thank you, Steve Talikowski. I found this incredibly informative, and thank you for sharing your ideas and commingling them. So I think our viewers have a pretty good idea of some of the pluses of a good physical therapist. I want to remind our viewers, please click the like button. There's our website right below, www.tosmri.com. We're glad to connect you with any of these providers who are all excellent and highly reputed in our community. And we can answer questions about TOS in general. Again, I'm Dr. Scott Worden, the TOS guy, and we'll see you soon.
Thanks, Scott.